A very good evening to all of you. New year, new beginnings, and new learnings. On behalf of Colitis Crohn's Foundation India, it is my pleasure and privilege to welcome each one of you to this webinar on refractory proctitis. Dr. Ajay Kumar, President, Colitis Crohn's Foundation India, will be moderating the discussion. Managing refractory proctitis is not easy. Though there has been an increase in the number of therapeutic options, we need to learn how to, when to best use them, and hence, what is the optimal management of patients with refractory proctitis. So today, the cases will be presented by Dr. Bhaskar Kante and Dr. Himanshu Narang. Our esteemed panelists include Dr. Ajit Sood, Dr. Matthew Philip, Dr. Vineet Ahuja, and Dr. Vishal Sharma. To begin with, the first case, over to Dr. Bhaskar Kante, please. Thank you.
Good evening, everyone. Myself, Dr. Bhaskar Kante, working as consultant gastroenterologist in Hospital, Hyderabad. I'm thankful to the organizing team for giving me opportunity to present in the webinar in front of eminent panelists and experts of IBD. Today, my topic of discussion is topical therapies, foam, suppository enema, and proctitis. We'll discuss it in coming 10 minutes. So we'll have a case presenting for 5 minutes, followed by theory on that. So going to the case, it is a case of refractory proctitis. Is a 40-year-old gentleman who is an auto driver by occupation, hailing from Hyderabad, with a lower middle socioeconomic status. He presented 2 years back in my OPD with symptoms of blood mixed stools for 2 months, with a frequency of 4 to 5 per day and associated with urgency. However, there is no history of any pain, abdomen, or fever. On colonoscopy, we found have disease limited to the rectum, which is complete loss of vascular pattern, superficial erosions, friable mucosa noted, and UCS noted to be 4/8, suggestive of a moderate disease. And the biopsy which was taken from the rectum is suggestive of with features of grip distortion and cryptitis, suggestive of IBD ulcerative colitis. So this patient is a classical case of IBD UC. So the traditional approach for these patients is step-up therapy, starting with oral and topical 5-MSA, followed by increasing the treatment to steroids, immunomodulator, if not responding to the biological such as anti-TNF, if not responding, then the surgery. So as per the guidelines, this patient was started on topical mesalamine suppository of 1 gram per day with add-on of oral mesalamine 3.6 gram per day in view of his moderate disease activity. So after using compliant to the treatment, he had response after 2 weeks. After that, he was maintained on oral mesalamines 2.4 gram per day. He was doing quite well for 1.5 years. Then after 6 months back, he had a relapse in the form of stool frequency 5 per day with UCIS of 5/18. Now we noted a disease migration up to the sigmoid colon with a picture of proctosigmoiditis. So in view of moderate disease, he was started on a high dose of oral mesalamine, and also he was started on mesalamine foam instead of suppository because of proctosigmoiditis. After using it still for 2 weeks, he didn't have any response. So the mesalamine foam was replaced by the hydrocortisone foam. Still, patient after using 2 weeks, he didn't have any response. So now we are dealing with a patient of ulcerative proctitis who is not responding to oral mesalamine as well as the topical therapy. So as per the guidelines AGA 2020 with ulcerative colitis mild to moderate patients, it recommend that in patients of mild to moderate UC who is refractory to the optimized oral and rectal 5-SA, it suggests using either oral prednisolone or budesonide MMX. As my patient was diabetic, which was initially controlled well on OHA, so we tried a budesonide MMX in my patient along with the oral mesalamine. However, after using 3 weeks, he still did not have any response, and unfortunately, his diabetes also worsened. So this is the case scenario of difficult to treat proctitis, which we often face in clinics and the IP patients who are not responding to mesalamine and conventional therapy. So at that point, we had a treatment options such as oral steroids or newer agents, biologicals, or surgery. But oral steroids were out of the option because of at that time he had uncontrolled diabetes. So we explained about the new biologicals as well as newer molecules like vedolizumab, ustekinib, and oral small molecules like tofacitinib, and is also given an option of surgery. Surgery he didn't opt because by profession he was an auto driver, so he has to work daily. And when it comes to the newer molecules, the cost again is the issue for it. So what does the guideline say in such scenario? as these patients of ulcerative proctitis is often neglected in the randomized control trials or head-to-head trials, but still the ECO guidelines for the severe patients, it recommends using in escalating the treatment to the anti-TNF agents or vedolizumab or ustekinumab or oral small molecules like tofacitinib. But in this subset of patient of ulcerative proctitis, do we have any real life scenario like using these molecules? Yes, we had a real life we had a study from the DMC Louisiana where it showed in the subset of patient of ulcerative proctitis who was steroid dependent, steroid refractory. There, the tofacitinib, if we induce with 10 mg twice daily followed by 5 mg BD, there it had a greater effectiveness when compared with the disease extent of left-sided colitis and pancolitis. So discussing all these options and various treatment modalities, cost and affordability, after discussing with my patient, the patient was started on tofacitinib. 10 mg initially induction dose it was added, and after 2 weeks the frequency and reading was controlled, and then patient started having clinical response. Then after 2 months, tofacitinib was tapered to 5 mg daily, and at the 6 months of follow-up, currently last 1 month follow-up, he was in endoscopic as well as clinical remission. So my final diagnosis of this patient is IBD ulcerative colitis who had a duration of 2 years with refractory proctosigmoiditis, who was initially not responding to oral and topical 5-SAs as well as topical steroids. He tried budesonide, which was not responding. However, he was responded to the tofacitinib, and he was found to be a clinical remission and endoscopic remission. Though this is quite often the real life scenario of patients who we encounter of ulcerative proctitis. So, what is the need of discussing these subset of patients, because these are often neglected in the trials? So, the burden, when it comes to the disease burden, how much significantly they contribute to the total number of ulcerative colitis? When we see the data from India, the first study, which is from All India Institute, Delhi, they showed up to 20% had this disease extent of proctitis and proctosigmoiditis. Another study from the DMC Louisiana, it showed approximately 44%. When it comes to the global, it is up to one-third of patients. So in total, approximately up to one-third of patients might have this disease extents, and which contribute to the significant number of ulcerative colitis. So understanding the treatment options in these patients is pivotal for the management of ulcerative colitis patients. So what are the treatment options available as per the guidelines? We have the topical therapy is the main cornerstone of this management of these patients. So among the topical therapy formulations, the first one is suppository. So coming to the physical property, it is in the tabular form, and on the parectal insertion, the 100% drug will be released to the rectum, and which will effectively act against the inflammation. So the second option is foam one. Foam is a liquid formulation, but it is a highly viscous when compared to the enema, and it will release us topically, reaching up to the 40 centimeters from the anal verge, coating the rectum as well as sigmoid. The other advantage when foam carries when compared to the enema, there is a 40% release in the rectum. So even patients who are not responding to the suppositories, foams are good alternative for such patients. Then third one comes the enema. Enema, the physical properties of enema is less viscous than foam. So when and amount of water when it carries, amount of liquid or suspension is up to 60 to 100 ml. So it is difficult for certain patients to hold that much of liquid suspension in the rectum, and patient often complains that they will often taking the enema, they will rapidly have to go to the washroom to because of the urgency or their disease activity. But still, the patient education can improve the tolerance to the enema. So apart from the physical properties, let's dig which therapy can be effective in which subset of patients. So how to decide which to use and when to use? So here we are not discussing about the drug or the molecule which is having the what type of preparation. We are more focused on it. So the major factors which will decide the therapy is the disease of extent. So if the disease is limited to the rectum, the suppositories are more effective. When the disease is limited to the rectum and sigmoid with a proximal extent up to 40 centimeters anal verge, then foams will be more effective. When it comes to beyond the sigmoid colon, the liquid enemas which carrying up to 100 ml is more effective because the drug reaches there. So apart from these physical properties, are the head-to-head trials or which they significantly show which one is superior? No, I'm not discussing exactly to it, but still there are not very good number of randomized control trials, but still some trials have shown that mesalamine preparations are slightly better with a slight p-value margin slightly better than the corticosteroid formulations. But what is most important when it comes to which to use, there is the patient tolerance. So this patient tolerance is again, it was highlighted in the a recent AJ guidelines also. So when it comes in patients with mild to moderate ulcerative proctosigmoiditis or proctitis, the AGA initially suggests using mesalamine enemas or suppository rather than the oral mesalamine. However, we can see the comment that patient who places a higher value on the convenience of oral medication administration and lower value of effectiveness, still you can choose oral mesalamine above the above the topical therapy. So the patient intolerance, the discussion with the patients, which therapy would be ideal for him according to his lifestyle and the disease extent, whether he can hold the enemas or not. So that is more important. So if the patient is comfortable in using the rectal therapy, then the rectal therapy is the main cornerstone of the therapy. If not, if it is not comfortable, then the oral mesalamine should be given in adequate doses. When we see the second recommendation 7, here also they have same highlighted. If patient places a higher value on avoiding difficulties with mesalamine enemas, then you can opt for the rectal corticosteroid foam preparation. So again, here the importance was also given to the patient tolerance. But when it comes to the actual guidelines, like in patient with mild to moderate ulcerative proctitis who choose rectal therapy over oral therapy, so there the recommendation stays like we have to use initially mesalamine suppositories and also mesalamine foams are ahead of rectal corticosteroids. So the main emphasis on this point is apart from the drugs and molecules, the patient tolerance and patient education is most important for the adherence and compliance to get the best results. So another most important factor which to use when to use which decides is the cost and the availability. So which is quite important in our settings. So when we see, let's see what formulations we have in the market and at what cost. So these are the topical formulations which are available right now in India. So we have suppositories with a chemical compound of mesalamine. There are two companies, the Misacol from the Sun Pharma, which approximately cost 50 rupees for 1 gram. So we often use it 1 gram per day. When it comes to the company of Ferring, we have with a brand name of Pentasa, which is again the double the cost. When it comes to the foams, we have mesalamine and hydrocortisone foams. So again, in the foams, we have a canisters. We have to get the canisters the patient has to use for the one actuations of misala foam carries 1 gram, so we can use per day. So it can last up to 14 actuations. So 14 days you can use. So it approximately costs 150 rupees per actuation. So that is per day. So when it comes to the foam enema, it is 115 per the actuations. However, we can have to use 10 actuations. So when it comes to the enemas, the mesalamine we have two companies, Sun and Ferry. The Sun is coming at giving at a lower cost of 130 rupees and effectively giving the 4 grams of dose. When it comes to Ferrings, we have 1 gram per 100 ml liquid suspension costing about 280. So the new kid in the block is tacrolimus enema, that is Tacfa enema from the Intas company. It is of 4 gram per vial and it's cost about 490 rupees per vial. So we have to choose the right formulations for your patients and discuss with them in detail. The paramount importance will be given to the patient adherence and the cost and availabilities because these patients are quite suffering from a good symptom burden, significantly affecting the good quality of life. The topical therapy, we have to choose it right. The key to success to get good response in such patients is choose your right patient with the right formulation at the right timing and the patient education about the formulation use, how to use and how exactly which position they have to use the canister and how to retain the enemas or foams for after using at least 15 to 30 minutes to get the better results. So this education should be given to the patient that will increases the adherence and compliance and tailor the treatment according to the individual patients based on the cost and affordability. So thank you.
Excellent presentation, excellent case, highlighting the various issues. And now we have the experts here. And my job is to ask questions to the experts and bring the thing in the right perspective. But Bhaskar, very well managed patient and good satisfied patient. I'm sure that patient is satisfied.
Thank you.
So the first point that which highlighted, which comes out from your case, that the initially patient presented with proctitis and later on it extended on to proctosigmoiditis. Vishal, are you there? I can't see you on the screen.
He's there.
Yes, sir. Yes, sir.
Yeah. Vishal, how often the disease in ulcerative colitis progresses from the first presentation? How often do you see that? Uh, and does it progress to a limited, or do we anticipate that in the future disease may progress to the rest of the as well?
Thank you, sir. I think it is a very important point that whether the initial evaluation, if we see is a limited disease, whether it progresses or not. So although there was a belief earlier that the progression is either not happening or it is very limited, but I think there is enough data to show that at least in ulcerative colitis, there is a progression of disease which may happen over time. If you are talking only about proctitis, then over 5 years, it is supposed to be around 20%. And over over a year, it is around 20%. And I think over 5 years, it may be as high as like 3/4 of the patients may actually progress beyond proctitis. Meaning thereby, that is why I think there's one recommendation which we all know that, even in patients who are relatively well off, you need to do a repeat colonoscopy at around 7 to 8 years. One reason is, of course, also to re-estimate the disease extent. So obviously, progression is well recognized in ulcerative.
Matthew, when a patient comes to you with this presentation of this thing, my very practical, I'm just basically, I'm asking the practical, simple clinical question that will you use only topical therapy, or will you like to add oral 5-ASA therapy to begin with? I'm talking about as a first choice. Will you combine the two, or you will start one drug? I mean, the options could be this, or could be that you start the two and maybe stop one. What is your approach?
See, what I do is I generally discuss with the patient. If the patient is very happy to have two suppositories or enemas, suppose a disease confined to rectum, in those patients I prefer to use that. But many times the answer is no, and we can sometimes convince them to have one enema at the night and not more than that. If you want to give two, for example, suppository also, most of the people are working, and the night they may agree. So in those cases, many times I start with the oral 5-ASA along with suppository or enema, local preparation.
Vineet, what is your approach? Because every patient who is not satisfied by us from the private, they will reach you. Okay.
Can be the other way also, sir. Both ways.
No. So what is your approach? What is your the
approach to a patient with
the same question which I asked Matthew? He said he will discuss with the patient and he will keep both the options open. What is the scientifically recommended approach, and what do you actually do in real life?
Sir, in proctitis, we start with the topical therapies. So we start with 5-ASAs, and subsequently, if the patient, we give 1 gram a day, and if the patient is doing well, fine. Otherwise, we add. Then the option is to start 5-ASA oral or to add steroid enemas. Now, that is the time. What happens is, if the patient is not doing well, then you would add 5-ASA. At the same time, also add steroid enemas after that. So once the patient has improved, then comes a choice about patient compliance. The patient is more comfortable with the suppository, or the patient is more comfortable with the oral tablet. If the patient has proctosigmoiditis, then obviously you have to give oral 5-ASAs. Then there is no point in giving only topical therapy. So, but we invariably start with topical therapy first. And even if the patient is not very happy with that, because that really gives...
I'm sorry, I'm stopping you, but how many of your patients complain two things? They can't tolerate the topical therapy, one, and two, or they are not able to hold on to it, both the things.
Any patient who has a very active disease, they will not be able to retain the enema at all. And if the enema is the larger proportions like 70 ml or 100 ml enema, they'll just not be able to retain it. As and when the rectum gets less and less inflamed, it becomes better for them. But at the same time, particularly if the inflammation is beyond 15 centimeters, then we give a combination of suppository as well as enema, because we have seen that enemas do not help, and adding suppository at that point helps a lot because the suppository stays in the rectum, and as a result, the rectum compliance also improves and patients are able to hold their enema.
When you're combining the two, what is your actual advice? When should they take one or the other? I mean, at the same sitting, different sittings? It's a
More
practical.
practical advice ki take one in the morning when you can lie down for some time, one in the evening when you're back home, and again you can lie down for some time. And initially, don't be unhappy if you're not able to retain it, because you will not be. If the disease is very active, you'll just not be able to retain it beyond half an hour or 1 hour or sometimes even 10-15 minutes. And as and when your retention power increases, you know that the disease is going down.
Bhaskar, you mentioned and you showed the recommendations that probably 5-ASA's topical therapy is better than the topical steroids. I mean, do you think the evidence is quite robust, or it's very subtle? And
So
I
again-
am surprised, actually. What I'm surprised is that I was not aware, but I was surprised that it has found a place in the recommendations without much evidence. That's my.
Yeah, yes, sir. That's what I stressed, because there is not much robust evidence, or the major difference is very quite low. So again, it comes to the patient preference and tolerance levels, and it is quite often we don't prescribe hydrocortisone enemas on a long-term basis, because there the mesalamine formulations are better. But as you highlighted, sir, it is a very conditional recommendation. So there is not strong, robust head-to-head trials suggesting that one is superior and one is inferior.
Then let me ask all the panelists, who will use as a first therapy only 5-ASA, or who will use steroid topical therapy, the Entoform, and of course, I mean, that's the only option that we have here on the Proctitis sigmoidatus I'm talking about. Who will use what? I mean, first therapy, 5-ASA, and how many of you combine the two?
Can I?
Ajit, aa gaya? Arre, I thought you were not around. I wanted to know.
No, Acha, sorry.
Great.
I thought that I like this question that proctitis. I think topical therapy remains the cornerstone, and we've been using enemas, but since the time methaqual suppository has become available, our practice has changed. And I'd like to say that our first choice, I will share with you what we practice, that even for proctitis, even for mild to moderate disease, we generally combine the two. Methaqual suppository 1 gram bedtime and oral mesalamine 2.4 gram OD. That is a standard. And for topical, for proctitis maintenance therapy, we decrease the suppository from every day to alternate day. Then we go to twice a week continuously. We feel that maintenance also suppository is a useful therapy. We generally keep both together for a long time.
So it's good for the delegates to please go with whatever you follow nothing is wrong. I mean, there are national experts here, and somebody is using only topical therapy to begin with, or somebody is starting with also will add on the two. I personally will usually add both the things. And but in a Proctitis sigmoidatus, that is very clear. There's no confusion about that. I think Vaneet made it very clear that you have to use oral. In a simple proctitis, the choices are open, whether you use single or a combination. I think both are justified.
There is a reason. There is a reason that there are few studies which have shown that if we combine the two, if we combine oral with the topical therapy, maybe the disease progression is less. I'm saying there are few studies to this effect.
Can I make a comment on that? No,
Yes, Matthew.
say, suppose the patient, I'm talking about only proctitis, and suppose the patient has, first time you are saying, it's not a severe one. Severe, I always combine with both. But if it is a mild or moderate, I always try to give only topical preparation. But Proctitis sigmoiditis, I always give a combination, because if it is a left side colitis, I always.
I think there's no confusion about that. For all the delegates, the message is very clear.
Ajit, suppose a mild or moderate rectal disease. Still in those cases, you start both.
Matthew, this is what I practice. I mean, I'll be honestly sharing with you. We combine the two. This is our practice here.
Honestly speaking, I also tend to practice the same, but I'm saying that both the approaches are right, whatever you're comfortable with. Is it okay? All the experts agree with that carry home message?
Many times it is not our comfort, the patient comfort is most important.
Absolutely.
There is not to use.
Yeah. Now, I'm coming to the relevant issue in this particular patient, that we have significant evidence of TOFA now in acute severe colitis came from Ajit's group. We have in mild to moderate to severe ulcerative colitis. I mean, in the literature, she showed some paper from on the left-sided colitis. Do we have any specific data on the TOFA in proctitis, this thing? Vishal, can you educate us on that?
I think, sir, there's a fair amount of data, including, I think, the paper from the Schultz group, I think, digestive disease scientists focused on ulcerative proctitis only and use of tofacitinib. So we have data. I think there's another paper in APT which talked about the use of tofacitinib in ulcerative proctitis. So we, because typically, the earlier randomized trials, these patients were excluded, and even now they allow for around 15% enrollment of proctitis patients. So we may not have direct data from randomized trials, but I think there is fairly strong observational data to support the use of tofacitinib in ulcerative.
Any comments on this particular issue from any other panelists?
My experience.
Ajit, your published data, what did it show? How many of them had a isolated proctitis?
We had, I think, out of 200 patients, 32 patients had proctitis, and the response to TOFA in patients with proctitis was better than those with left-sided and pancolitis. So, I mean, for us, it's a good addition to patients who are refractory to steroids or are steroid dependent.
That is the point, I think, sir, which should be highlighted, that refractory proctitis, tofacitinib is a good drug. Not in every case of proctitis, tofacitinib should be started, because the other trial, which I think Himanshu would be showing, also took patients which were refractory proctitis, in the sense that those who had been failure to topical 5-ASA, oral 5-ASA, topical steroid, oral steroid, their tofacitinib was used. So that is the message we should go across, that refractory proctitis, yes, tofacitinib is a good drug.
See, I think, for any biologics or oral small molecules, we actually consider only when it is a disease which is become refractory.
Vineet, while you are there, the last question before we go to Himanshu, what do you think are the unmet needs in the therapeutic armamentarium of proctitis? I mean, one thing which I have strongly felt for many years, that you do not have a good, even steroid suppository. I mean, I'm just giving one example. And two, do you think there should be there's a place in future for the topical therapy of TOFA?
Yeah. So there is space for that. And I think studies are going on for that in terms of tofacitinib enema in patients with this thing. So basically, any topical therapy, any immunosuppressive topical therapy, because the topical therapy is not meant only for proctitis. As we all know, that even in patients with left colitis, pancolitis, whenever they have active disease, the rectum is the major site of inflammation. So whatever you give, the major site of the suppositories or the foam enemas will act best on the rectum. So you have to combine topical therapy even in all those patients who have pancolitis or left colitis. So everywhere topical therapy actually is as much important as oral 5-ASA in every patient. So the more choices you have, the better it is. And you have 10% to 20% of cases of proctitis who are refractory proctitis. So all those 10 to 20% of refractory proctitis, they require tofacitinib or they require biologicals, or they may require, some of them, 2% of them may require surgery. So in all these cases, if you have more choices available, definitely the patients can benefit. And one point out here which should be highlighted again is that before you decide that it is refractory proctitis or something and jump on too many enemas, always rule out chlamydia or something. Some of them, often these kind of cases are presented in various conferences, that the patient has proctitis, not responding to anything, and then turns out to have chlamydia. So that is something which should be.
For the benefit of the delegates, can you please also elaborate what test you do for chlamydia?
So chlamydia, we do the PCR, sir, for chlamydia and the rectal biopsy. We do that. And otherwise, I don't know what other people do, but we have been doing that. And otherwise, in case, even if you are not able to, let's say, do a test, then you may give a therapeutic trial of doxycycline for 5 to 7 days. And that in a way answers the question, even if that test is not available.
And I wanted to comment on the steroid suppository.
Sir, and any kind of, every topical therapy is welcome, sir.
You know why? Once I have discussed with multiple number of pharmaceutical firms. You know why they don't market it? Because it doesn't give them profits and it doesn't have a good shelf life. But I don't understand why everywhere in the Europe, steroid suppositories are available and patients import from there.
Yeah, what is more important is budesonide suppository is very much required. And second,
I'm glad that you raised that. Yes, Ajit.
Yeah. Like you mentioned, chlamydia, Vineet very rightly mentioned. I would like to share with you that we had recently 4 patients of syphilitic proctitis.
You started.
You know, we have forgotten.
After the narcotics in Punjab, now you are getting syphilis, no?
I mean, I can't imagine. I read somewhere that we should not forget syphilis. Can you imagine? I mean, 4 cases of syphilitic proctitis. And they would have been labeled as proctitis, otherwise would have been on steroids and all other drugs for IBD treatment.
How did you suspect that and how did you test it?
The picture is different, and one that they have more of a mucopusy discharge rather than blood per rectum. And the ulcers what we see are not diffuse. Like the classical feature of proctitis what we have when patients have ulcers. The ulcers in ulcerative colitis are always merged in inflamed mucosa. While ulcers in infectious diseases will always be isolated and nodularity. There will be ulcers on a nodules kind of thing. And the surrounding mucosa will not be as inflamed as we see in ulcerative colitis. And it's a very, very limited disease to the 3-4 centimeter distal in the rectum. So that is how I became suspicious and we got VTRN and it was positive.
Good.
Dr. Ajay, can I ask a question? See,
Yes.
We don't have budesonide enemas or budesonide as suppositories. Do you think that will it be better than conventional steroid enemas? Do you think it would be better? Because it is available outside India. It is very commonly used by people. And when they come to India, they ask us whether it is available here.
It's a very common problem. And most of the Malayalis come, as it is, are coming back from outside only. They don't live there. Okay. Vishal, I've not forewarned you, but I'm asking you in the next 3 minutes, if you can just sum up the carry home messages from this discussion for the delegates, then we move to the next case.
Yeah, I think...
for everybody, if you can sum up the carry home messages.
So the carry home messages will be that proctitis, although many people believe is easy to treat, but it can be one of the most symptomatic problems in ulcerative colitis. Of course, it can be associated with progression of disease, and in a subset, it may be refractory to standard therapies when they don't respond to topical or oral ESAs and or steroids. In that case, there is a need to there may be a need to use advanced therapies and occasionally need for surgery. The initial approach to therapy of ulcerative proctitis should definitely be local therapy, that is suppositories of 5-ASA plus or minus the oral ESA, but certainly never oral ESA. And certainly, I think if you think that it is not directly fitting in with ulcerative colitis, important to rule out infectious causes of proctitis, especially sexually transmitted infections.
Well, friends, thank you for all the panelists for this particular case, and special thanks to Bhaskar for presenting us a great case and generating good discussion. Can I request you to introduce the next speaker, please, and then go on to the next case?
Okay, so the next case will be presented by Dr. Himanshu Narang. So Dr. Himanshu is MD DM from AIMS New Delhi and also finished his IBD fellowship from AIMS Delhi and is very interested in inflammatory bowel disease. So Himanshu, please present us the case.
So I thank the organizers for giving me the opportunity to present this case. So We have a 29-year-old gentleman, no comorbidity, symptomatic since 2016, with recurrent large bowel diarrhea. Initially managed with complementary alternate medication outside, had subsequently bloody diarrhea. Colonoscopy done revealed multiple superficial ulcers throughout colon, and based on biopsy, was diagnosed with IBD ulcerative colitis. He was initially prescribed oral 5-ASA agents, and subsequently he clinically improved. Colonoscopy we have of 2019 shows normal mucosa till ceca. However, in 2020, he had acute severe ulcerative colitis, sigmoidoscopy showing multiple superficial ulcers. He was managed with IV steroids and discharge of oral steroids and azathioprine. He continued low-dose steroids and azathioprine, and we have a colonoscopy of May 2021 showing diffuse loss of vascular pattern with superficial ulcers till ceca. He presented to AIMS IBD clinic in October 2021. His oral steroids were tapered, and azathioprine, oral 5-ASA agents, and topical 5-ASA agents and topical steroids were continued. He did well for more than 1 year. However, in February 2023, he presented with one flare, and he was started on tofacitinib, deeming him to be as have been failure. He initially did well. However, in November, he again had worsening symptoms requiring dose escalation of tofacitinib. But in December, he was admitted with acute severe ulcerative colitis, with sigmoidoscopy showing UCIs of 5/8. He was managed with IV steroids, and he was offered the option of infliximab or colectomy, which he refused, and he requested that his tofacitinib be started again. He took tofa for 6 months. However, 6 months later, he again had worsening symptoms requiring dose escalation. And in November, we have a colonoscopy report which shows that sigmoid colon and upper rectum are normal, but the lower rectum shows the diffuse loss of vascular pattern, edema, and erosions. He presented to us with recurrent bloody stools with tachycardia, and this was the sigmoidoscopy report. So the sigmoid colon had normal mucosa, but the rectum had diffuse loss of vascular pattern, erosions, and multiple small ulcers. So we have a patient, IBD ulcerative colitis, currently E1 disease, which is steroid dependent, azathioprine non-responsive, tofacitinib failure, and he is now presented with refractory proctitis. He was managed along the lines of acute severe ulcerative colitis. Stool CRH toxin ELISA was negative. X-ray did not show any myopollen, and rectal swab PCR for chlamydia was also negative. He was started on IV steroids, prophylactic anticoagulation, exclusive enteral nutrition, and topical steroids. However, despite continuing this therapy of 5 days, he still had persistent symptoms. Stool frequency was 5 to 6 per day with frank bleeding. So what are the options that we have till now? Now the option that we have is either induction with infliximab or cyclosporine induction followed by maintenance with vedolizumab, or of course then there is surgery. So coming to proctitis, so the guidelines recommend that initially inducing with topical 5-ASA agent or plus minus topical steroids, and for maintaining with topical 5-ASA agents. Also, detailed guidelines are given by the CCFI consensus treatments on using 5-ASA agents. And these are based on multiple studies which have shown the benefit of topical 5-ASA and topical steroids in multiple studies and even systematic review and meta-analysis. So refractory ulcerative proctitis is defined as failure to induce remission in 2 to 4 weeks with topical 5-ASA agents, topical steroids, oral 5-ASA agent, and oral steroids. And the disease is said to be steroid refractory if the disease is active despite prednisolone up to 0.75 mg per kg per day over a period of 4 weeks. One therapy for proctitis is topical tacrolimus. So this was a randomized controlled trial done in 4 centers in Australia where topical tacrolimus ointment in dose of 1.5 mg per day, twice a day, were given for 8 weeks in 21 patients with proctitis who had failed topical and oral 5-ASA and steroid and who were on immunomodulators. The primary outcome was clinical response at 8 weeks, and the authors found that there was significantly better clinical response rate, clinical remission, and mucosal healing in patients on topical tacrolimus compared with placebo. Another study was conducted regarding positioning of topical tacrolimus, and this was a randomized controlled trial done in 8 centers in Netherlands and Belgium involving 85 patients with ulcerative proctitis. And tacrolimus suppository 2 mg OD was compared with beclomethasone suppository. And the authors found that there was similar clinical response, clinical remission, endoscopic response, and endoscopic remission rates thus concluding that the efficacy of both the suppositories is similar. So these are the various studies, the prospective, retrospective studies, and the randomized controlled trials, which have mostly shown that there is a good benefit with topical tacrolimus. However, the issue is that the studies are done, the sample size is very less, with the maximum size being 85. Also, the duration of therapy is mostly around 4 to 8 weeks, with only one study having a duration of more than 20 weeks of topical tacrolimus. Coming to biologics in proctitis, so as previously discussed, that in the most of the major trials, the even disease is an exclusion criteria, and even if in some trials they're included, there's a capping of around 15 to 20%. So the data for biologics in proctitis is mostly from multiple prospective and retrospective series, and these have shown that anti-TNS and vedolizumab have a clinical response rates of 45 to 70% and clinical remission rates of 35 to 50%. Then comes the small molecule. So these have also been evaluated in patients who have with proctitis who have failed anti-TNF therapy. So this was a study, a retrospective study done in 17 French centers involving 35 patients with proctitis, of whom around 90% patients had failed 2 biologics. The authors found that tofacitinib led to very good clinical response rate of 60% induction and 45% at 1 year, and 43% at steroid-free remission rate at induction, and 39% at 1 year. Thus, concluding that tofacitinib is a very promising therapeutic option in refractory proctitis. A similar study was done in India from Professor Ajit Sood Sir's group. This was a cohort study involving 180 patients with steroid-dependent refractory ulcerative colitis, of whom 32 patients had proctitis. And it was found that clinical remission rates were 46.9% at week 8 and increased up to 59% at week 48 in proctitis patients. Another small molecule is etrasimod, the data has been published in a post hoc analysis of Elevate UC52 and Elevate UC12 trials, and the authors have shown that the clinical remission rates range from around 42 to 44% at induction and at 1 year. Another option that has been studied in the past but is currently a knowledge gap is the rural appendectomy. So this was a case here of 50 patients of proctitis who were followed for 3 years, and in 80% of patients who had appendectomy, there was an improvement in clinical activity, and in 30% patients, all therapy could be discontinued. Another case series of 8 patients who were followed for 3.5 years, all patients were found with proctitis were found to have mucosa healing. 50% patients had moderate flare, but that responded to topical 5-ASA alone. Various other therapies have been tried, including some herbal therapies. However, the data is very scarce and these are not used. One interesting study that we found was the role of mesenchymal stromal cell injection in proctitis. And this was a phase 2 clinical study in refractory proctitis patients. These 13 patients have received the mesenchymal stromal cell injection, and at 6 weeks, there was clinical improvement clinical Mayo score and in full Mayo score, thus opening the doors for larger studies in phase 3 studies of the mesenchymal stromal cell injection in proctitis patients. So coming back to our case, we had a patient who had presented with 6 to 7 stools per day, 1 per night with frank blood, who was initially on admission treated with IV steroids, but in 5 days, he was still having persistent increased stool frequency with blood. He was switched to oral steroids, and now tacrolimus enema 4 mg OD was added, and he was followed in the hospital. And in 1 week, he had improvement in stool frequency, and the bleeding also stopped. And after 1 week, he was discharged. He came for follow-up after 2 weeks. He was still in clinical remission, and this was the endoscopy report. The sigmoid colon had normal mucosa, and the rectum also had complete mucosa heating. UCS was 0/8. Further plan for this patient is to continue tacrolimus enema 4 mg OD for 4 to 8 weeks, taper oral steroids, and in case of relapse, plan is biologic infliximab or option of colectomy. So take-home points. So ulcerative proctitis can present with refractory symptoms requiring biologics, small molecules, or even surgery. Tacrolimus enema may be considered in patients with refractory ulcerative proctitis, and more data is needed for evidence-based management and positioning of therapies for refractory proctitis. Thank you.
Thanks, Himanshu. Can you stop sharing your screen? Yes. Very interesting case. quite a bit. So we have about now 12 to 15 minutes for the discussion. Vineet, let me ask you. I mean, Himanshu showed a nice this thing, E3 going into E1. Now, do we actually believe that this happens, or do we see that, do the patients behave like that, and how often they do that?
So it is the same percentage, like 20 to 30% of patients progress in terms of extension of disease. 20 to 30% patients also regress in terms of extension of disease, that they would have presented with E2, but subsequently, initially they may have had E2 or E3 and they may go back to E2 and E1. So it can occur both ways. So in this patient, there was a regression of disease, but the proctitis was very severe, so much so that because of proctitis, the patient went into acute severe ulcerative colitis. Prior to that, he had tofacitinib failure and all those things. So,
just by my knowledge, have the people done the histopathological studies in a situation like that? I mean,
if you do a histopathological study, then in that case, you may find that microscopic involvement may be there. That has been done even for cases which are E2. And when you look for microscopic involvement, you may find that actually it is E3. But then the definition for ulcerative colitis, when you're talking of extent, is based on the macroscopic involvement, based on the endoscopic involvement. So we never may decide E1, E2, E3 based on microscopic involvement. We decided based on macroscopic involvement, that is the endoscopic involvement. Yes, in terms of long-term prognosis and all, if somebody has microscopic involvement going on to E3, yes, that may have a different kind of prognosis, but as such, no, macroscopic involvement is the...
Honestly, what you were saying, I was personally not aware of the data, but when I saw the case, then I can recollect that, yes, I have seen patients who behave like that. But I didn't.
Actually, it's like the mucosal healing which is occurring. When you give any patient biological, they heal completely. You may find even colon is totally normal, not even disease. They may have a E0 disease, in sense that you may not find any ulcerative colitis, and that you find even with steroids. Some patients, you give first course of steroids, they come back after 3 months. You do a colonoscopy, you say, who diagnosed you with ulcerative colitis? You don't have ulcerative colitis at all. And the same patient then comes back 6 months later with a frank flare showing ulcerative colitis. So this kind of evanescent mucosal healing and all will keep on going on. So
can I ask a question?
Yes, but I was about to ask you the same. What is I wanted to ask both you and Ajit, what is their experience in this?
I just want to get a opinion from Vineet through you, Ajay. See, this is regarding when a patient...
You follow the right channel, upper channel.
When you treat a patient with, this patient you have seen, initially the patient had an extensive disease, almost involving right colon also. And when you treat a person, we expect the healing is almost throughout. And why this patient has got refractory proctitis in spite of all the treatment? Why you think that rectum is not healing?
Suppose it was just sigmoid was also involved, then you would not have asked me this question. Then you would have said proctosigmoiditis, you would say fine. Rectum, again, the reason for that is the rectum is the commonest site of inflammation, is the major site of inflammation. If rectum heals, then everything heals. If rectum does not heal, then rest of the areas will not heal. So ultimately it is the progression. It's like how healing starts. So the rectum would be the last to heal, and that is the reason why rectum is spared in very few cases of ulcerative colitis, only in cases of PSC or where you have like pediatric cases, etc.
When you treat a patient of extensive colitis and the patient has significant rectal symptoms, we give some local topical therapy in them, and many times we are seeing the rectum is relatively better when compared to other area. And even histologically, it has been shown that, and they ask us whether the patient is on a topical therapy because the rectum is less.
Yeah. So that's a whole spectrum. So Dr. Matthew, that's exactly what the entire spectrum of ulcerative colitis is. It can range from 0 to 100. So it depends upon where this patient falls into.
Okay, let's move ahead. Ajit, I will like your comment also on this, but beyond that, my next question to you. See, we saw a new therapy here in the so when we first saw the new therapy of a TOFA and in a refractory. Now you have a beyond TOFA, or it's a parallel to TOFA, what it is, or that tacrolimus. What do you have any experience, and what is your comment on that?
Yeah, thank you.
And for that also, please contribute to the discussion which we just had.
Right. Thank you. And like we always say, ulcerative colitis is a disease which occurs in continuation. There's only one caveat to this, that when a person is in remission and the disease is coming back and the relapse is happening, that is the time when disease may have a patchy appearance. But we always say that the disease begins from rectum. Like in this case, it's basically predominantly proctitis at the moment, but we have not done his colon. It's a sigmoidoscopy finding. So I think we need to be very cautious that he may have some changes in the proximal colon because we have not done a complete colonoscopy. But good thing is that he responded very well to TAC topical therapy. Coming to TAC topical therapy, I mean, this drug has been available to us for a long time. We have been using oral therapy, but like cyclosporin, there have been side effects. The good thing what is happening with TAC topical therapy is that the blood levels don't reach really up to the level which they occur with the oral therapy. And though at the moment the data is very limited, but most of the patients, they have not gone beyond 5 nanogram per ml. So that is a level which is fairly safe and which doesn't put a patient in high risk of adverse effects. So I think this is a very good addition. But when we say that the main indication is proctitis, I am happy to have a TAC anemia, but I'll be happier to have a TAC suppository.
Absolutely. That's a very well important point that INTAS people are there listening to that you have an anemia, why don't you have a foam or a suppository? Yes.
If you look at whatever data Manchu actually showed, I think the most disappointing was the tacrolimus suppository. I don't know why. I mean, there was some one randomized trial where ointment was used with apparently good results, and lot of observational data with anemias where the tacrolimus anemia seemed to work. But apparently, I think there was one randomized trial with the suppositories which were seemingly as good or as bad as steroid suppositories.
Beclomethasone. It was with beclomethasone. Sorry, we participated in a trial with the TAF anemia with the budesonide hydrocortisone anemia. There was a trial going on. I expect that the results will not be far better than steroid anemia, but the side effects profile may make us use more of TAC.
In that context, can I ask a question? See, we are actually comparing two drugs. One is used in acute proctitis, so-called ulcerative proctitis, and another is used for refractory proctitis. And we don't use refractory proctitis, we don't use steroids. We are actually trying two drugs are used in two different situations. So is that right to do that?
Yeah, you're right. I think Dr. Matthew's comment is perfect that tacrolimus says the data is for refractory proctitis. Steroid is in a way first line therapy immediately after 5-ASA. So that is something which we have to remember, and both of them get absorbed. Tacrolimus also gets absorbed from the rectum. Steroid also gets absorbed from the rectum. The only thing is that if you're using 4 milligrams, then the absorption rates will not go out. And if before these, this phase 3 trial, which was done by INTAS over many centers across the India, before that, we have been using tacrolimus suppositories or enemias because people have been making it at home. They have been taking the tacrolimus capsules, and subsequently they have been trying to just insert whatever the tacrolimus ointments which are coming, not the capsule, the tacrolimus ointments which are coming. They have been inserting that rectally because tacrolimus is very difficult to dissolve in water, unlike prednisolone which can get dissolved in water, unlike tofacitinib which can get dissolved in water. So for our poor patients, we dissolve prednisolone in water and they take them as anemia form, and their results are very good, extremely very good, and also to the cheapest form of anemia. And is even effective.
Actually, we used to use it so often in PGI, but some other days seems to have gone out of fashion now.
No, the problem with when you use a homemade preparation now, that those formulations, we cannot guarantee the dosage of that. It may have very wide dosage. Suppose now they put a capsule or they use a...
you can regulate the dosage. Suppose you would say, okay, 20 milligrams of prednisolone tablet. So you're regulating the dosage. Similarly, tofacitinib, if you can regulate the dosage. So that is there. The only thing is, yes, it is for people who cannot afford anything. There are a lot of people with proctitis. Supposedly, the minimum cost was 50 rupees to 100 rupees. It is more expensive than 5-ASA. So if you are going to give topical therapy to somebody for even 1 or 2 months, that means the minimum cost is going to be at least around, means 5,000 rupees to 10,000 rupees or something like that. So those are by homegrown remedies. That's different. Let's come back.
With this case, sorry. So in this case, I'm saying that now that you have to stop TAC after 4 to 8 weeks. We don't really know how long we can use this. Why don't you put him on mesocal suppository and maybe in combination with hydrocortisone enema? Because when we use two together, the response rate is better than when you use single drug alone. So maybe it does very well. We don't need to use two biologics.
See, I'll come back to all the panelists for their final comments on where do you place this particular new drug in their algorithm of treatment. I'll take one line from each, but before that, we have to answer two questions from the audience. First question from Devish Prakash Yadav from Varanasi. Can UCEIS of 5/8 behave as acute severe ulcerative colitis? Vishal, I'm passing on this question to you.
Yes, sir. I mean, UCAS typically, you may have a UCAS of even 4, and you may have acute severe ulcerative colitis. And second is, I think it is in relation to proctitis. Then sometimes even proctitis can present with something like acute severe. Not very common, but does.
Next question to Vineet from Kiran Joshi Kanjmala from Cochin. There is a maximum duration and maximum number of escalation to 10 milligram of TOFA after de-escalation can be tried.
So you can go up to 16 weeks of induction period, and you can even go, some people are going even beyond 16 weeks now for induction period. And you can go for as many escalations and de-escalations you want, because it's not like a
The question had two components. One is induction therapy, for how long you can try that, and number two, how many relapses you can use. So I think Vineet has answered both the questions. Yes, Ajit, you would like to comment on that? You are the maximum.
I think it's fine. I agree with Vineet, and people have used it even 10 milligram twice a day, even for longer periods of time also. And it depends actually if a person is responding. I mean, there's a response, we can continue, but we need to keep it in mind that if this person is not responding, there's no response, then there's no point in continuing. But if a person is definitely showing response but not achieving clinical remission, we can definitely prolong the therapy.
So I think we are finishing our time. We started in time, so we should finish in time. So Ajit, I start from you. Where will you place, one second, there's another question which is cropped up. In infants, not to forget milk protein allergy related proctitis, which very much mimics like UC. Dr. Abhijit from Nagpur. Thank you, Dr. Abhijit, for adding to the good discussion here. This doesn't require any answers from the audience, from the delegate, from the panelists. Yes, Ajit, where exactly will you place the tacrolimus anemia in your clinical practice algorithm? That is Vineet, and then Matthews, and then Vishal.
Refractory proctitis. My choice in patients with refractory proctitis, because we got more experience with TOFA. So once a patient has refractory proctitis, if I have to choose a drug, I'll go for TOFA. No response, I'll go to TAC anemia.
Yes, Vineet.
So refractory proctitis, I would like to use a good topical therapy. So if my other therapies have been exhausted, and I would first use tacrolimus, and if it does not work, then I'll go to TOFA and biological therapy. But again, not to be used in pregnancy, not to be, pediatric data is still not there, so one may not use it out there. So I'll give it a trial for 2 to 3 weeks. No response, then move over to biologics, surgery, tofacitinib, anything of that sort.
Matthews. Matthew. Vishal.
I can just take one line, that TOFA's advantage being that we can continue this as a maintenance therapy. While for TAC anemia, we have to switch to another therapy.
If Matthews is there, still there?
Yeah.
Otherwise, Vishal, departing, last comment from you.
Sir, I agree that tofacitinib, we also know that it can be used for maintenance. may be cheaper actually to use tofacitinib. The only thing being that probably even a long-term use of rectal tacrolimus may be fine, because whatever data we have on estimating serum levels seems to be very supportive. The levels have either not been detected or have been fairly low to be of lot of relevance. So maybe we may in future have data for long-term maintenance even with rectal tacrolimus.
Well, friends, there are still more questions cropping up, but then we have to respect the limits of the time. And with that, I'll take this opportunity to thank, first of all, special thanks to Dr. Himanshu Narang for enriching us with a wonderful case and introducing us to the use of a new drug on the horizon. Okay, and then of course all the Matthews is back. Matthews, any of you are just summing up the whole thing, and your special thanks to all the 4 eminent faculty, and that is Dr. Vishal, Dr. Matthews, Dr. Vineet, and Dr. Ajit, for sparing our valuable time and enriching us with the new knowledge about this disease, which is a very interesting disease to manage and can be a really bothersome for the patient's quality of life. And patient can be
Thanks to the intelligent moderator.
Huh?
Thanks to the intelligent moderator, smart moderator.
First speaker also Bhaskar, and to the very intelligent moderators.
Okay. Thank you very much.